Okay, Mr. Chairman, ladies and gentlemen, I want to speak about the augmented reality as a development. Scopis company is a startup company in Berlin. I work with them, but I have no financial interest and no support, so I have nothing to disclose. Allow me a short look back when we speak about navigation. This was my first experience with navigation nearly 20 years ago with the VTI technique. Patients had to wear head frames when they came into. They went into the CT scan with the head frame as well as in the operating theater. We connected our instruments to the unit and we got quite a good picture 20 years ago. And what we saw was a cross, and this was the tip of the instrument. Later, this was my second experience. A camera came into our OR with infrared camera, and we had to put reflecting markers on our instruments as well as beside the table, and then we started our surgery. And we did a lot with calibration and accuracy here in an operation together with our neurosurgeons, reflecting markers on the face of the patient. All these things were done, and what we got was the computer-assisted surgery, the image-guided surgery. But what we got also 20 years ago is the standard of today. We display the current position of our navigated instrument in the operating field. This is the standard for today, what means navigation. But we have our challenges for the computer-assisted surgery. We want a high probability for daily use. That means we need an easy handling, a short setup time, and a universal utility. And our benefits, which should come out from the navigation, should have high accuracy. We want to have an easy localization of difficult structures. And in focus of our interest is the fusion of navigation with the endoscopic and microscopic picture, and maybe the augmented reality. What means augmented reality? Augmented reality means we want to add additional informations, like landmarks, drainage pathways. This is our aim of our surgery, to improve the drainage pathways. So specific points of interest should be marked: tumors, malformations, post-traumatic changes. We have to identify these in the CT scans. We call it target points. We also can identify anti-target points as well as bony structures we don't want to pass or we want to reach. So the key factor for the augmented reality is a simple, nearly simple thing. We want to have an optic calibration of our endoscope. So we need a calibration device and a universal endoscope adapter. And these two things, together with an algorithm, allow us to calibrate our instrument. Here, in a time of round about 10 seconds, we can register our endoscope to the system, and then we can start immediately going into the nose and see our pre-registered markings inside of the CT scan. This is the precondition. But you can see and we can follow these points. And when we look to this screen, we can see there is a distance marking between the tip of the endoscope and the marked point in our CT scan. We can also measure the distance between the tip of our instrument and the marked point. This was the first step. But the thing was, why only target points? We want to have more information how we can go to these points. So we started to identify objects inside of our anatomy, and we identified the structures like the pathways as well as the pneumatized cells inside, or pneumatized structures. We called it shapings and positionings of blocks inside of this anatomical labyrinth, and we wanted to shape our passage pathways. So we identified the target-guided surgery, and target-guided means we make a planning with a 3D graphic software. We analyze the anatomy, and then we draw into this analyzed anatomy on the 3D scans by drawing blocks and drawing pathways. And then we can utilize this planning for the optical guidance when we use it in the navigation system. So the idea was how to use these anatomy, and we have classifications where we have analyzed anatomic structures. And in 2016, there was a group made for the frontal sinus, a new classification. And the idea was behind this new classification that we have a precise identification of the anatomical position of pneumatized cells or pneumatized structures. We can call it cells or blocks or any way other things. And this is a more complex display of these anatomical structures. And this classification gives support for better communication when we use these anatomical structures when we start with our analysis. And then we can use this identification especially for the frontal sinus drainage pathway, which is our aim. And then these results can use for the target-guided surgery. Here a short overview. It is very simple. We have anterior cells, posterior cells, medial cells, and maybe you are familiar with this. We have the Agenesi cell, superagenesi cell, and then we can have also pneumatized structures going into the frontal sinus. And what you can see, we have anterior parts of pneumatized structures. And when we look more detailed, we can have also the bulla block, where we have the bulla etmoidalis and the suprabulla cells. And these suprabulla cells can also stretch into the frontal sinus along the skull base. So we have a posterior compartment. And between the anterior and posterior compartment, we can draw a line, which is the natural pathway line. And this is what we want to identify also in our previous, before we start with the surgery, with the analysis in the anatomy. We have other structures like the supraorbital ethmoidal cell, as well as the frontal septal cell, which make some modification of the drainage pathways. So this is the result, what we can do. We can use these blocks shaping, and we can identify our pneumatized structures, and then we can mark the drainage pathway by this specialized software. We can use all kinds of classification, older classifications, new classifications, but what we need is a marked classification here and a marking inside of the anatomy. And this is the result. What you see is the blocks, and you see the drainage pathway. And this light purple ring is connected to our instrument. And when the ring closes, we have the confirmation that we are along our pathway. So we can go along our planned structure, and we can control it in the 3D scan. We can also change to the 45-degree optic and have the same confirmation. We can look where the pathway goes to the floor of the frontal sinus, and when we open the structure along our pathway, we have the confirmation. We can click in the pathway again, so that we have really confirmation that we stayed on our pathway along the surgery. This is also possible for other sinuses, like you see the opacification in the sphenoid sinus, polyps in the sphenoethmoidal recess, and you see a complete vanishing situation in the recess. But our pathway structure gives us a clear confirmation the way we had to go. And then after removal of these polyps, we have also a very good side inside. We see the fungus inside of the sphenoid sinus. And here you see a revision case of a frontal sinus. We marked the blocks, and we see the pathway structure. And along this pathway, we can really make our preparations. We see where we have to remove this tissue, and where we can clearly open the frontal sinus so that we clearly see where we can go, and we get the information that we are in the right position to the frontal sinus. Well, if we compare image-guided surgery to target-guided surgery, we see no guidance to target structures in the image-guided surgery. But the advantage of target-guided surgery is the optical guidance, and we need at first the analysis of patient's anatomy, and we have to define the targets. So we can say we have a new generation for the surgical navigation by this system. But modern techniques allow a fast setup time for surgery, and so our surgery is not really prolonged, and we can support with our plannings and the detection of the structures inside of the surgery, and the surgical maneuvers can be more easy and more precise. Navigation does not replace the knowledge, but the planning and the analysis can improve it. Thank you very much.